Good afternoon, everybody. Thank you very much for joining this live webinar. Today we're going to talk about technology and remote monitoring for health, and particularly in the context of diabetes in vulnerable patient groups. I'm very pleased to welcome with me today Paula Fernandez, who is a diabetes specialist midwife at the Royal Surrey Hospital, and also Dr. Daniel Morgenstein, who's an endocrinology and diabetes consultant at Chelsea and Westminster. And my name is Lucy McKillop. I am a Chief Medical Officer at Sensign Health, and I'm going to start off today by talking more broadly, I guess, about remote monitoring technologies and how they are evolving even as we speak. What I would like to say quickly, and it's already in the chat, if you've got any questions, please do put them on the Q&A panel, and what we will do is sift through them and answer as many of them as we can in the live environment, and then continue to answer them after this webinar is closed. So without further ado, I'm going to start with talking about remote patient monitoring and how it's also changed and evolved in the pandemic. Next slide, please. I'd like to talk a bit about sort of technology and where we've come from and going to in the next 10 years. I'm going to talk about some of the challenges associated with adoption of technology, and then look at some used examples, including GDM Health, which is a remote monitoring and management application for women with diabetes in pregnancy. And then also we're going to go on and talk more broadly about the management and monitoring of diabetes in other patient groups outside pregnancy. Next slide, please. So this is a publication from 2017, which is probably the best one to illustrate what is happening worldwide. And what we've seen is a burgeoning of technologies, particularly in the health space. And what they've done is they split this into the sort of wellness management sort of space, like sort of sleep patterns and things like that, and then also specific health condition management. And what you can see here is when they looked at apps available in 2015 versus 2017, there was a gradual decline in the wellness management apps, which to date had been the sort of the major ones, but a huge increase in health condition management, a 48% rise between 2015 and 2017, and that has continued to rise since that date. Next slide, please. Thank you. And in that publication, they explained that there is obviously a high and increasing level of smartphone ownership. And at the point of the publication, there were 318,000 health and wellbeing apps available, with it increasing at a daily rate. Pertinent to our discussions today, 9% of those apps were related to women's health and pregnancy, which is interesting, quite a big number. And they estimated that the global mobile health market was valued at 25 billion in 2017, with a projection that digital health applications in just 5 patient populations, diabetes prevention, diabetes generally, asthma, cardiac rehabilitation and pulmonary rehabilitation, could save the US health system £7 billion a year. Next slide, please. So we have been promised, if you like, this sort of technological sort of explosion, and that is exactly what that publication suggested. But in real life, you know, I work as a clinician, we haven't necessarily seen all of that. We do have electronic health records, and the primary driver from that, of course, was billing to begin with. So particularly in the US, was how we itemize the health care that the healthcare system is providing. But we as clinicians were promised increased efficiency and cost saving, increased data accuracy, increased accessibility to information on our patients to help us better care for our patients, increased connectivity, and of course it being environmentally friendly by the fact that we were going paper free. But I think we've all experienced the other side of the coin, which are the barriers to adoption in technology, and there's a very valid concerns. There are valid concerns regarding information governance and security and privacy concerns, legal responsibility concerns. So if I'm served up with this information 24 hours a day, what happens if I'm not looking at that information and something happens to the patient? Where does my legal responsibility lie? Also, there was an absence of provider incentivization. So certainly in the US, it's obviously less important in the UK, but in the US, you get the healthcare system gets paid for the activity it does. And if you are seeing somebody remotely, the health system gets paid less money than if you're seeing them face to face. So where's the incentive then to use these technologies? There was also a lack of evidence, and I think many technologies came out and they didn't have really the strong evidence base that, say, a drug or a vaccine did have, and there really wasn't the framework around to evidence these technologies, and that led, understandably, to clinicians thinking, well, I'm not sure it's really the right thing to do. And we were left with these sort of rather unwieldy, unintuitive EHRs, electronic health record systems, which tended to feel like they increased our workload rather than decreased them, and certainly was implicated in clinician burnout. At the same time, there was sort of regulatory issues, and frameworks were not really keeping up with the technology. So therefore, there was nowhere for us to go to find out which app would be better for this particular condition compared to another app, because there was no guidance to help us to score them, if you like. And of course, we have to also be mindful that many of these apps were in English, and therefore potentially disenfranchised both people whose English weren't their first language, but also maybe increased health inequality for those who maybe didn't have smartphones, etc. And we have to be very mindful of that when we're thinking of developing these products. Next slide, please. And then COVID hit. And you know, it really has changed the dial on our technology use, I think. I mean, in my own practice, I moved from virtually no remote consultations to over 80% of my consultations being remote. You know, there's been a huge expansion in particularly video consultations, but also in remote patient monitoring, and that's what we want to talk a little bit about more today. Next slide, please. I've mentioned already GDM Health, which is the remote monitoring technology for women with gestational diabetes. And you can see here the number of trusts using GDM Health from May 2020, or sorry, May 2019 through, and there's been a sharp increase since May of this year. And of course, that is in line with the COVID first wave pandemic. So in February 2020, we had 16 hospitals using GDM Health, and now there are over 44 hospitals in England using GDM Health. And that has increased because of the requirement, the need for us to help to continue to effectively monitor and manage our women, even when it is not necessarily safe for them to come up so often to the hospitals and to the clinics. And so we are facilitating the stringent social distancing that the government have suggested for pregnant women, for this vulnerable group. But I also want to touch on another point, which is the data generated from this initiative, this remote monitoring system, is also very interesting. So we have fully anonymized data from over 14,000 women and their babies now, and you can see there that equates to 2.7 million blood glucose readings, and we also have evidence of maternal and neonatal outcomes as well. On the next slide, I want to show you some of the work that we're beginning to do to try and improve the care of pregnant women and their babies, the outcome of their babies, based on the data, the anonymized data that we are able to generate from the real world use of GDM Health. Next slide, please. So the first clinical algorithm that we have developed and is currently being reviewed by the MHRA pending CE marking was to look at which patients, which women are most likely to transition to needing pharmacological medication, so tablets or insulin. And at the moment on GDM Health, there is what we call a heuristic algorithm, which says, you know, after 3 blood glucoses in the same time of day, that might be an indicator for medication. But what we've managed to do is, using these vast quantities of data, we've used machine learning to pick up what actual variables that we're able to collect influence the decision by a clinician to start medication, and therefore we're able to predict a week ahead which women will require medication. And this has a real potential to help reduce time to intervention, because we can prioritise which women are going to need medication, or to help to redouble efforts for non-pharmacological medication, because we can say, well, look, actually you're heading onto a trajectory for medication unless there is some sort of more profound dietetic changes. We could also maybe help to shape different care pathways, and that might help with resource limited clinics, for example. And it also standardised decision making and helps to support the wider team to develop pathways so that these decisions are not left to one or two people. So I think this just shows you the power of a remote monitoring system that is being used in clinical practice to help to monitor and manage women with gestational diabetes, but at the same time is generating real world data which we can then use to improve the system that we're using, and in so doing hopefully benefit both the mother and, in this case, the baby as well. So that is the end of a sort of more of a sort of an overview of what we want to talk about today, and I would like to now introduce Kate, who has a very recent lived experience of monitoring her blood glucoses during her pregnancy. And I think it's really powerful to hear from Kate how technology has maybe helped with her sort of care during her pregnancy, and also particularly during the pandemic, because this is very recent, her experiences, and also maybe some of the challenges that she has found with using these technologies. So Kate, are you there?
I am. Hi.
Hello.
Hi.
Thank you very much. Very nice, very kind of you to come on today. So do you want to just sort of set the scene a bit about where you are and how recent this pregnancy was?
Sure. So had a baby about 2 weeks ago. So I was fortunate enough to kind of get the opportunity to use this from about 33 weeks pregnant. So I've probably been using the system for the last 3 months or so, primarily for a couple of months, and then just kind of have the ability to just continue to kind of check in and make sure that my sugars are kind of starting to behave themselves a bit more. This is my second pregnancy. I didn't have GDM diagnosed in my first pregnancy, and it kind of got flagged up during the course of monitoring for this pregnancy, and then got referred to the diabetic specialist team, which is how I got access to the system.
Thank you. And what were your initial feelings when they were offered you the GDM Health app? I mean, what did you feel?
To be honest, I was just quite surprised, because it just seemed like a really sensible way to do things. Because one of the problems that I'd had, that I think a lot of pregnant women at the time had is quite understandably just access to specialists and just being able to get hold of specialist teams in the middle of a pandemic, because particularly for second pregnancies, quite honestly, you're not used to having as many appointments during your pregnancy, because you're sort of expected to kind of know what you're doing, even though it was a little while ago. So anyway, and then when she went through it, I was just a bit surprised that we had access to that sort of thing. So and then she kind of went through it, and it just seemed like it would work and just be very easy to self-monitor, which was useful.
Great. And did you find any challenges at all with using it, or did you feel you still felt you had a good communication with your healthcare team?
I think actually a much better communication team than I would have otherwise had, and it just the fact that they can kind of remotely monitor it, and then you got kind of supervisory messages kind of text effectively to you, which was quite a reliable way of communicating, because trying to get hold of teams, I think especially at the moment, but just in general when you're dealing with quite a busy centre, and getting hold of precisely the person that you wanted to speak to in quite a big team is usually quite difficult. Yeah. So actually knowing that they've kind of got an oversight and they're reviewing your results that you're inputting, and they can just message you directly, was actually much simpler and just much more time efficient. And then you kind of knew exactly where you were. And equally, communication, if I had any worries, I could message them or get a message to them if I needed to, just requesting them to give me a call.
Great. So the sort of bi-directional communication was a sort of very much positive. Excellent. And was there anything else that you particularly liked, or you found helpful, or I don't know?
I think that one of the things that I did really like was the fact that because with any other monitoring, particularly if you're having blood tests and stuff, you're often not necessarily told if they're completely normal, and kind of just being able to kind of self-track, and it also particularly for things like blood sugars was really useful if you're kind of making changes to your own diet, and you can actually see pretty much immediately whether actually you can eat that wholemeal pasta but the other stuff less good, but you can kind of adjust and change as you go, and it gives you a bit more control and feedback. You're not just kind of left wondering, well, is this okay? And the way it kind of color codes things as well, so you can see whether yes, that's fine or that's less good, was really kind of helpful in terms of not having to remember specific numbers but knowing that actually your range was fine.
Brilliant. So you would say that it sort of facilitated sort of self-care and self-management.
Definitely. And also, and it sounds really silly, but the idea that somebody else is sort of peering over your shoulder and just kind of interested in your readings meant that you did them, which is particularly if you've got like other small children running around, you can sort of forget sometimes, but it meant that you did kind of keep up with it because you were sort of accountable, but indirectly, if that makes sense, because you knew that somebody else was this was of interest to your clinical team as well as being able to form your own decisions, basically.
Fantastic. And did you use it all the way up to the end, to the birth of your baby?
Yeah, and then and actually it was very useful for the attending midwifery team, because I had a section, so I stayed in for about 36 hours after that, and actually, just because I think firstly it's quite a busy time on the wards, but secondly just because of staffing and COVID and everything, that actually when I brought my monitor with me, they were just quite relieved that I could just do it myself. And just put it on the system, because particularly with the timings and stuff, it has to be an hour after you've eaten, and they didn't necessarily on a couple of occasions have the staffing to do that, I don't think. So I think that was really useful, and then to have it that you can use afterwards as well, so you can see if your sugars are kind of kicking back in afterwards, has been really useful.
Great. And obviously usually women will be diagnosed with an abnormal result after a glucose tolerance test, but obviously during COVID many trusts were using the Royal College of Obstetricians and Gynecologists guidelines, which suggested that we stop doing that. And we had some screening using HbA1c and blood glucose. Am I right in thinking that actually you screened okay for those, and actually it was because you were using the app that you were actually diagnosed with GDM?
Yeah, absolutely. So I had screening anyway, kind of early in pregnancy, I think just quite routinely, and then it got flagged up again just because my baby had a big fat tummy on a scan, and again, yeah, absolutely, all of the screening tests, so my fasting blood glucose and my HbA1c were plumb normal, and it was only because I was just getting really thirsty, and I mentioned it to my midwife, who said, well, we can just speak to the diabetes team, and it was only using this app that actually I could kind of demonstrate, no, my sugars are going above 7.8 if I don't eat the right things, and that was how I got diagnosed in the first place. So without that, I wouldn't have it wouldn't have flagged up at all, so it was really helpful. And then on subsequent scans they've commented that actually, yeah, no, the kind of things that look like they're improving, and my control certainly got a lot better once I was much more conscious of it. So yeah, it was amazing from that perspective.
Lovely, thank you. Do you have any other comments or questions or comments that would help with the with our audience, if you like? Any other things you want to add?
It was, I mean, just because of kind of being pregnant in a pandemic sort of time it has been quite scary, in just because I have lots of friends who have been pregnant at the same time, and I think the level of engagement and the level of kind of care particularly because of this app and because of the processes, because of this and the level of monitoring, has just been hugely reassuring. And it's something that I've had friends in a very similar circumstance, not in region, who haven't had access to this, who have honestly just felt a little bit kind of left on their own, and for lots of different reasons. But I've just been hugely grateful to have access to something like this. I think it's been absolutely fab. So thank you.
I love well, thank you for giving such an honest opinion, and it's really lovely to hear that all went well, and baby is all well and healthy and happy. So that's fantastic. Well, thank you so much for joining us today. So I think next slide, please. So I think the next person to talk is Paula. And Paula, as I said, is a diabetes specialist midwife from the Royal Surrey and County Hospital, and she's going to talk about her own experience and that of her team and her hospital's experience with using GDM Health. Thank you very much, Paula.
So thank you for having me. It's been a good experience having to work with you guys and the app. So just to give you an idea how we started here before COVID and after COVID situation. So next slide, please. So when I started, it was a need to have a role as a midwife, because at the beginning it was only a couple of midwives with interest on diabetes that were working, covering kind of 2 days a week, and they were only able to do phone calls or one-to-one appointments to start doing a BM profiling for patients, and that was taking a lot of time. And then once I started the role, we changed it. We managed to get a full cover for the week, Monday to Friday, between the three of us, and we modernized a bit, having more emails and group sessions, so we save a bit of time in that. Next slide, please. So what happened is we were seeing how the number of patients were coming through was quite increased, like in no time. So we were seeing that we were taking too long to really approach every single one of them. Don't know if the next slide is coming. So basically we got to an agreement. We see that this app was available, and we thought that this is why we need it. Because it was taking too long to get patients to engage with us, following them, calling them. Maybe I didn't document it, and then my colleague was calling again the following day, so disturbing the patient. Said, well, I already give you my results. It wasn't really the best approach. As I said, so doing double or works. And that was a way, having this app was a way to have all more like a standardized practice and be a bit more modern and go with the times. And you know, we thought this is really, really good. So very soon we adopt that into the clinics, and despite the first kind of uncertainty or people a bit more scared of using it as anything new, after a while it was well appreciated. Next slide, please. So what I can tell you, what we really managed to get here, and that was proof even before, on the first year of using the app before COVID, was amazing. So we reduced to more than half the number of emails that we were doing. More than 70% or around 70% of the calls were reduced. And also the number of appointments that we were giving to the patient. So that gave us a bit more time to really intervene and to give a plan for the patients quicker. And that was something we, you know, doctors, endocrine team, everybody was really pleased to see with that. But especially we see that we could reduce the weekly clinics. So we didn't have like to overbook patients, they have to wait for too long, because we have these kind of was much better. So next slide, you can see, please. You can see that we did an audit to see how was our workload on the first. The data I have available was for the last three years. So from 2016 to 2018, it was almost double of the people that we were seeing to do BM profiling. and most of them, almost more than half, was really diagnosed with gestational diabetes. So it was a lot of people coming through our doors that we wanted to monitor, and that was very good to have the opportunity to use the app. So we thought, yeah, that is the right move, and we proved that right. Next slide, please. So before the COVID, we already knew that it was helping us as a team, multidisciplinary team. Everybody was involved. So the diabetes nurses were really pleased that they could focus more on patients having insulin rather than have to answer calls from patients with that diet only, control, because maybe they couldn't get through me on that specific day. So we kind of organize our own clinics and space. Also, we noticed a lot of satisfaction from the patients who had diabetes in the past using the normal way, now using the app. They were really pleased because, as it's been said before, they feel like, okay, I have my own autonomy, but at the same time I feel good because I got someone who is looking after me. We have the joke here, we say it's like the big brother that I can watch you. So I will tell the patients, don't worry, I'm watching you, so you're okay. And also that reduced the number of face-to-face visits, because we just have the ability to send a message to the patient and they respond and act quicker to say, well, I think your readings are going higher, let's modify this, or I can refer you straight away to the dietitian to help you on that. And that was a huge improvement for the whole team and the patients. We could manage to change or approach the patient quicker within 2 or 3 days and change the treatment rather than waiting a week for them to come to clinic or send us the results. So that is a very good outcome for us. Next slide, please. So then here comes the COVID-19, but we were really pleased because within a week we managed to provide a safe and efficient service during the lockdown. Quickly we create YouTube channel for the diabetes team, where we put all the videos in there for the patients to check. So every single thing we were teaching them face to face in the group sessions, we managed to put in there, and they are very pleased because they can go back to that anytime they need to through the treatment. So it's very good. We have less phone calls saying, oh, can you explain to me again about this, or what was the food I could eat? So they have it all in there so they can check. We changed all the consultations or as much as possible to video calls for the patients or telephone consultations. They have the possibility to have, if they didn't want to have the glucose tolerance test, we offer the home glucose monitoring through the app for all these patients, and it was well received. They have the possibility to receive them in the whole equipment in the houses, because it was posted by the company Matrix, and they have the drive-through cabin to collect the as well if they were locally or they wanted to come here without coming into the hospital. So because some of them wanted the equipment straight away, so we could do that. So it was really good in that sense. Next slide, please. And also the GP surgeries were really pleased with that, because we just set up like an emailing system, so they will receive the details of these patients that needed the prescription for repeat needles and or strips, whatever it was needed for this process. And it was really good. I mean, the feedback during this time was very good, and we help other trusts as well. We pass in the information how we were doing this model so quickly to help them. We didn't have a problem with that. We just wanted people to be safe and happy. So thanks to the app, we were able, as I say, to continue monitoring 100% of the cases that were referred to us. We respond within maximum 72 hours for all these results that were above the targets, and deliver the medication safely with the nurses, with ourselves, with pharmacy, all working as a team. It was very good to see the whole team, David's team, working together. Because everybody has access to the app, we can just contact someone and say, please, doctor, can you review this lady and tell me exactly when do you want to see the patients, how we move this, blah, blah, blah. So it was really, really good. And everybody felt even more comfortable, because sometimes when you don't see the patients as you plan every 2 weeks or 3 weeks, you feel like you're missing something, but having the app was really, really good. Next slide, please. And yeah, it helped us as well to kind of have the patients having a normality, kind of a normal life. So for me, from the point of view of midwives, it's been an amazing change in a good way, because it gives me the possibility to focus on the patient's needs and give them more time for you know, do you need more help with your diet? I can help you on that. You know, you can have people with different needs. But also from the emotional point of view, we have a lot of ladies really worry about the COVID situation coming to the hospital. So having that reassurance that I'm here, I'm watching you, you're not alone, you're not missing your appointments because we got this to help you, was really, really good. We can also prioritize what patients needed to be actioned on, because we got the alerts. So instead of going by one, we can say, well, these are the ones I need to focus now, and then I'll continue with the others. Reduce the number of emails and calls that we have to do. But also just having these phone calls, consultations when possible, was saving money to the trust as well in this situation. So I think in general, everybody benefits from that. And it was really, really good to see. But from midwifery point of view, is that I can stay with the women, so I can help them not just focus on, okay, I need to get the data and then see what we need to do. I have time to send them message to encourage them to do you know, you're doing a good job. So that was really good. Next slide, please. So yeah, what helps me here to explain is that we have a look of what, since we started the app, using the app in this hospital, up to the beginning of this month, we've seen 955 women have used the app. So it's an average of 45 women a month starting and downloading the app. Of all of those that are being diagnosed with gestational diabetes and then to continue monitoring the sugar levels until the end, most of them are on diets only. And sometimes that make me think that it's because we managed to action on time to tell the patients to change the diet, to change and trick things around so they don't go into medication unnecessarily. Well, sometimes they need it, it's fine, but I think that we give them the opportunity to manage it well from the beginning, but also because it's a big number of ladies that we need to follow. With diet only, we can support them in the daily basics, and it's really good. And for those who have medication like insulin or metformin, we can follow them with the app quickly and adding them to, you need to change your insulin, just increase the dose without having to come to the hospital. So that was very good. Next slide. Thank you. So overview of that is very good, as I say, because the patients can upload the readings straight away, so we can see. And sometimes we call them or text them before even they realize that the readings were above targets. So it's quite good for them. So what is an app that helps us a lot, and it's been mentioned before, is that they have the button to request a callback, and that saves a lot of time. And for them, it's really reassurance, because instead of waiting, having to tell the story, why aren't you calling, leaving a message, then one of us trying to call them back, when we see that in the app, we call them. I mean, it's not instant because we're busy as well, but they know that within the day they will be called because it's different parts of the team will, people that we're working on that. So I think it's very good. And also we can see review all the data, so we can see how they're progressing, if it's getting higher, if we need to action quick. So we can warn them before and prepare them for, yeah, I think you are towards medication, we need to get prepared, mentally prepared, and that helps them a lot to don't feel afraid. Next slide, please. And overall, as I say, it's a lot of financial benefits, because if you save money on the face-to-face visit, we also looking forward to a more normal treatment. So when it's in diet control only, having a specialist diabetes midwife have that kind of opportunity to look after this lady. So they only see the consultant around 36 weeks, if all is okay, because they don't need to see the consultant, because we do in the monitoring, as the NICE guidelines ask, weekly or every 2 weeks through the app, and they feel more normal. They don't feel too medicalized, and that changed completely the experience of the pregnancy, and they are more prepared and more empowered for birth. Also, we can prove that some of the scans are not needed, so we don't add more confusion for the patients on that sense to book them on appointments, when we have an app that we can see that is going well, and we can plan exactly at what time they need of the pregnancy they need the scans. And yeah, so we find benefits using the app through lockdown, because we managed even to reduce the consultants. They used to come 2 consultants for the endocrine team to us because of the amount of patients. Now we manage with just 1, because we up to date with the patients. So it's very, very good. And from my point of view, all my clinics has been done over the phone, and I only see them if they pop in for a scan or something. So it also gives them the opportunity to feel safe at home. So yeah, I hope it's useful for you to see my point of view of having this type of remote monitoring. I think is great.
Thank you so much, Paula, for that overview of your experience. That's fantastic. Now we have a couple of questions. What I'm going to do is going to leave that to the end of the presentations and do the questions all together, if that's okay with everyone. So Paula, thank you so much. That's fantastic.
You're welcome.
I'm going to now move on to ask Dr. Daniel Morgenstein whether you'd like to talk to us now a bit more broadly about remote diabetes care in the probably non-pregnant population, I should think.
Thank you, Lucy. So yeah, I'm a diabetes consultant, but I have not looked after women with gestational diabetes for the best part of 20 years. So what am I doing on this webinar? Well, as service lead for diabetes at Chelsea and Westminster, it came to me to sort of sign off, approve the funding application for implementing GDM in our antenatal clinic. And looking at this, this was a couple of years ago, and my immediate thought was, I'm sure we can make use of this in the wider diabetes population. And that sort of thought got slightly filed away at the back of mind until back end of last year, beginning of this year, even before COVID, when we started to think about what a transformation of our diabetes service might look like. So if I could have the first slide. And these are really the conclusions that we came to. So we know that diabetes is mostly in type 2 and always in type 1 diabetes a lifelong condition. And despite advances in technology, in treatment, particularly in the advances in structured education to support self-management, many patients continue to need help from their healthcare professionals in managing their diabetes, especially with medication adjustments and especially with insulin dose. We've known for a long time that the degree of glucose lowering achieved in trials of insulin is frequently greater than that we achieve in routine care. And we know that in trials you use quite robust insulin titration algorithms and almost certainly critically regular contact between the trial team and the patient that we struggle to achieve in routine care. We know that multiple visits to diabetes clinics, diabetes centres, hospitals are undesirable for patients and healthcare professional teams. And many centres were, even before COVID, routinely using telephone or email consultation or follow-up to try to manage and help support their patients. But that there was a gap there in terms of the technology for getting glucose readings from the patient remotely to be able to guide them. And I'm sure you've all either had or seen people struggling with patients either reading out glucose readings over the phone or emailing lists of blood sugars from their glucose meters, which is laborious, time consuming and prone to error. Move on to the next slide. So I think all of these challenges became even more acute in March. And I think, if you remember back, we quite rapidly realised and had quite early data saying that patients with diabetes were at high risk of more severe COVID-19, and that almost certainly correlates with glucose control. So the patients with the highest HbA1c are at the highest risk. These are therefore all the group that's highest risk of COVID is also the group that was in most need of support to achieve better glucose control, frequently needing insulin dose adjustments. And we really had to make, as Lucy has already described, almost an overnight major switch from face-to-face to remote care. And that really stretched the capabilities of our current systems to identify the patients who were at risk, identify who we needed to be working with in the first place. And certainly stretched our limits of how we could actually obtain their glucose readings and offer sensible advice without bringing them back to the clinic. Next slide. Now, it's what to say, there are solutions out there. So patients who are using many of the continuous glucose monitoring devices or the flash glucose monitor, like the Libra, have access to web-based portals into which they can link through their mobile phone and upload their glucose readings. And we've certainly found those very useful. And for our sort of highest risk patients, type 1 patients on these technologies, we've been able to use that to be able to guide them in their management. But with current NHS guidelines, it's unlikely that more than 15 to 20% of those with type 1 diabetes and almost nobody with insulin-treated type 2 diabetes is going to be eligible for these devices funded on the NHS. And we needed an equivalent solution for capillary glucose monitoring and for the vast majority of patients who are still using and will be for the foreseeable future finger prick tests. Next slide. So this is where we've sort of went back and thought about GDM and sort of started to mull over what I previously thought about, and we sort of talked to our colleagues running the antenatal service and thought about what were the benefits they'd seen of using GDM, which, much as you've heard about previously, it was enabling prioritization of patients, improving communication, reducing face-to-face visits, and that really led to us thinking really this could be the solution for other patients as well. Next slide. So this led to us reaching out to Sensine earlier in the year and thinking about what an equivalent product would look like outside of the diabetes, and Sensine come back with this model of DBM Health. And in terms of this screenshots here, you can see very similar sorts of views to the gestational platform. So the ability to look at an individual patient's glucose readings across the day, across the week, so that you can identify where improvements are needed. You can give the patient targeted advice for improving their glucose control. And on the next slide, but crucially and uniquely, and things like some of the continuous glucose monitoring platforms and things don't offer this, the ability to manage your caseload. So the ability to sort your patients, select them based on things like time in range, filter your patient list so that your diabetes healthcare team will be able to identify which patients need support at any particular given time and focus on those patients who are the priority each day. So if we move on to the next slide. So we are in the process of setting everything up so that we are getting all the approvals, putting things in place for a pilot of this system. What are we looking for? So these are what I and my team think are going to be the benefits of using this system in insulin-treated patients outside of pregnancy. So we're hoping to see an evolution of the benefits seen in GDM health to people living with diabetes outside of pregnancy. Crucially, we want to support remote care for those using capillary self-blood glucose monitoring. And I think an absolute key point is that this does not need any additional high-cost technology. It only needs a glucose meter that is on almost all CCG's approved lists for routine use, and one of a large number of compatible smartphones. We want to be able to use this to manage a caseload. So I think this is, again, one of the key aims for us. We want our diabetes nursing team in particular, but the whole multi-professional team, to move away from which patients we'll be seeing today to here is a cohort of patients who needs attention today. We hope to see improved clinical outcomes, therefore, through more targeted supports for patients. We hope to see the same sort of efficiency savings you've heard about being shown with GDM, and we want to help support patients away from hospital, especially during the remains of the COVID pandemic, with potential for long-term benefits with improved control. Next slide. So how's it going to work? This is really a variant of the slide you've already seen from the GDM talk. So essentially, patient uses a glucose meter that communicates with a smartphone, which uploads its information to a secure cloud environment, and the clinician can then log on to that and review all of their patients' glucose readings, allowing two-way communication between the patient and the healthcare professional team, requesting advice and feedback being given through the system. So a healthcare professional will therefore use the dashboard to review the submitted data, filter patient lists by criteria such as time and glycemic range to identify who needs support, and feedback suggestions like insulin dose adjustments back to the patient. Because this works through a secure cloud, it's web-based, it won't need software installed on NHS computers, etc. Next slide. And from the patient's perspective, they will have the app on their phones, which they will be able to use to annotate their blood glucose data with meal tags, medication doses and other comments. They'll be able to review their previous data graphically and spot trends, and we would hope that that will actually allow for many patients the self-management education, things like Daphne principles, to kick in and make adjustments themselves, and they'll be able to request a callback from the diabetes team whenever they need additional help. Next slide. So when we start to think, therefore, about the wider benefits, I focused a bit on the benefits that we anticipate seeing or hope to see in the first few months, but over the longer term. Better communication, hopefully improved adherence, and the ability to detect which patients are not monitoring and offer additional support to them. The same sort of audit processes as we've seen in GDM, the ability to track patients who are not getting benefit. We hope this will improve our capacity to deal with particularly more complex patients, particularly by freeing up time, improve reliability, especially compared to that sort of reading out your glucose levels over the phone that I described at the beginning. And with the potential to develop this app to include self-help guides and more diabetes information, hopefully it will empower our patients and support self-monitoring and to go hand in hand with structured education. And next slide. And I'll stop there and happily take part in the Q&A session.
Thank you very much, Daniel. That's fantastic. So we've got a few minutes now to answer some questions, so please do add them to the Q&A if there are burning questions you have. Paula, I hope you're still on the line because we've got a few questions for you, if that's okay. Paula, the first question that's come through is, are any or all of your midwives or you prescribers, or do the doctors prescribe?
No, not yet. We need to go through all the process. That was the next step for me to do as a specialty diabetes midwife. At the moment, we got all the doctors on board here to help us with the metformin. And if anyone needs insulin, it goes to the nurses team.
Sure. Okay. So your diabetes specialist nurses do that, do they?
Yes,
Yeah.
yes.
All right, thank you. And then there's a couple of questions about scans. You mentioned the potential for a reduction in the number of scans because of the use of GDM Health, and a couple of people want to ask you to expand on that.
Yeah, well, it's basically when before having that, if the patient didn't have like the readings and all that through the app, more control, then it was more likely to have, when they go and visit the midwife, it was more likely to find or suspect, I don't know, polyhydramnios, things like that. So now that they are more controlled, they don't need to do, let's say that we set up the scans as the NICE guideline says, so we don't need to do anything early because they are well controlled.
So what you're saying is you're able to fulfill the NICE recommendations on scans. You don't need to do the extra scans because of.
Exactly.
Yeah. Thank you. And then there was a question, implementation question. So prior to COVID, how did you implement things in terms of the app? Did the patients start by, or did you ask them to download the app before they came to clinic, or did you sort it out once they came to your clinics?
A mix of both. So the first, let's say 6 months, we were asking them to come to the clinic, and we do all for them because we have one-to-one appointments, and then we did group sessions where it's about 8 people coming at a time. So that's how busy we used to be. So we didn't have enough time to do a one-to-one. We keep a couple of slots there for people who maybe have bad English or any other, you know, they didn't want to be in a group, so we respect that. But in general, people like it to be in a group so they don't feel like, oh, you're telling me off, just me, more people like me. So that helped for them to kind of bond as well. But after that, we, and that's why we went so quick with the COVID. We were moving ahead, so we planned already the videos, at least from the midwifery point of view. I recorded a couple of videos, and we have everything like a template email, so we send it to them, so we're saving time to ourselves. Like, we have about 45 women downloading the app every month. We need to have things ready, otherwise it's crazy. And we are all human. Someone might be off sick or go on holidays, so we have to have things ready. So if we are not there, the service is still running. So that's what we did. So we have all in place for them. So some of them, now what we do is we send them the instructions on an email with all the videos. So before they come, they know what they're coming for. They have an idea. And we still ask them to come now. So we do the, let's say, the activation code and the pairing, the meter with the phone, because some of them might not be so good with the technical stuff, so it takes us 10 minutes. And then when they come, they can ask the questions they have, but they are more likely to do all over the phone. So that is saving us a lot of time as well.
Lovely, thank you. And then I think one last question. How often do you check the app? How often do you
Well, we do every day. We're lucky to be, well, mostly every day. We lost one member of the team through COVID, so it has to be isolated. So it's still 2 midwives doing it, but we have the nurses as a backup to check the app. We do every day when we are on site. Because we have the opportunity. I know the trusts maybe they only work part-time and it's more difficult, but we do every day.
And would you be able to estimate sort of how many hours a week, sort of cumulatively, you are looking at the app and assessing the data?
So I did kind of my own audit here, and we can say that we spend an hour and a half a day of our role to check on the app. Because just think that we work as a multidisciplinary team, so we kind of split a bit the clients. So sometimes, or the patients, we sometimes tell the dietitian, these are the patients. I send an email and said, can you review these patients? Can you give them a call? And then I check on the others. So we work really well as a team. And then on Thursdays we go the diabetes clinic, and then is when we have a list, or I have a list of patients that I want them to to review and tell me, okay, are you happy with this plan? Shall we do this? When would you like to see this patient? So yeah, about an hour and a half a day minimum watching the app.
Lovely.
Mondays could be a bit more because of the weekend.
Thank you very much. And do you have any women who have type 1 diabetes on the app? I know that from our data about less than 1%, but some women, it is from a regulatory point of view, women with type 1 diabetes are able to use GDM Health, but I don't know in actual clinical practice, what do you find?
We only have a couple of them at the moment because they normally have their own device, and
yeah,
I mean, we offer it and they choose what they want to do. At the moment, I think, well, now it's only one because the other deliver.
Lovely, thank you.
You're welcome.
Thank you very much for that. So then there's a couple of questions, I think, for Daniel Morgenstein. I think one is about, well, it's more about functionality of the app, actually. Sarah, I don't know whether you'd like to come in here and talk about this. One's about specific glucose monitors, and another question is regarding filtering with professionals' responsibility. I can answer that if it's. And Sarah, do you want to?
Yeah, in terms of the blood glucose meters, we work alongside Argomatrix. So it's the Jazz Wireless is available to work alongside both GDM and DBM in the first instance. There's also a manual entry route for people that aren't able to access that particular meter. So we can certainly get anyone in contact with the team to get ordering some meters if they'd like to proceed.
Thank you. Sorry, I've just got another question now saying that I inferred the question wrong. So, Dr. Morgenstein, there's a question about type 1 diabetes. So, do you anticipate when we have DBM Health up and running that this will be predominantly for people with type 1 or type 2 diabetes, or both, or what's your plan?
So, I mean, about 80% of our patients have type 1 diabetes in the hospital clinic. Clearly, this is not the solution for patients who will fulfill the criteria for continuous glucose monitor or Freestyle Libre, and we're not targeting that group. But the vast, we still have a huge majority of patients with type 1 diabetes who do not fulfill NHS criteria for those advanced technologies and are reliant on continuous glucose monitoring. And we absolutely think that will be a solution. Clearly, there will be, I suspect, a small number of patients who, for whatever reason, aren't happy to have two separate meters, one for ketones and one for glucose monitoring, where this isn't going to work, or they will have to use manual entering. But for many patients, yes, absolutely, we would anticipate patients with type 1 diabetes who need a period of intensive support, but don't fulfill funding criteria for Freestyle Libre or CGM would be offered this.
Lovely, thank you. And then I think one last question, I think, before we close. There's a question about filtering your caseload. So when this is up and running, do you anticipate that you'll be seeing patients, or you'll be reviewing patient data that's not your data, and you're going to caseload them? Is it going to change to a way that you deliver care more as a team than an individual consultant, or how do you see it's going to work?
Yeah, absolutely. So I think this supports a move to team-based care, and I think if we've learned nothing else over the last 6-7 months, it's the realization that any member of staff can disappear at any stage for a period of time, and team-based care, I think, has got to be the way forward.
Lovely, thank you. I mean, I think also we've found, certainly using GDM Health in my hospital, that actually the healthcare professionals that have had to self-isolate, they've used this from home, and so we've been able to continue to utilise their skills and knowledge despite the fact they've been unable to have a patient-facing role. So actually having this has been useful on two fronts, if you like, and it's kept them engaged and feeling part of the team, even though that they're unable to be in the hospital for the pandemic. So I think with that, I think it's time that we wrap up this webinar. I'm very grateful for everybody that has joined. I hope you found it informative. We will continue to answer your questions on the chat for the next few minutes, and please do reach out to us if you'd like any more information. And I'd like to finish by thanking Daniel and Kate and Paula for their excellent presentations and the information and honest opinion, which I think was really, really useful. So thank you very much.